A is a broad classification, and some of this will tie into what we talk about with our next lecture on when we get to the athletic lectures, okay? So this, you can see his mouth is a labor. I just put that in there for viewing pleasure. But here's some interesting facts, and this was a study that was done by Snyder back in 1990. It's been replicated several times, and it kind of never changes. The thing that you have to realize is that when we're talking about 6% of patients from the general population having some sort of slack lesion, this is a heterogeneous group of people. And if you look at athletic groups specifically, those who are involved in frequent overhead activity, the prevalence is about 35%. So it's much higher in that subgroup of individuals. But we're looking at this broadly, and I think it's good to do this because sometimes you'll say, oh, I think this person has a SLAP lesion. Well, SLAP lesion is kind of like a degenerative process for most people. So, Manuela's a climber, and so more than likely she has some form of a SLAP lesion that we'll be talking about today, probably one that's not significant enough to do surgery. Unfortunately, the surgical procedures that are done now are much generally reserved for bigger lesions. It used to be that, if you had a type 2 lesion, particularly if you were in the private sector, physicians are happy to do something about that, but the results are equivocal. They really don't need surgery. And so this will help kind of give you some perspective about that. But this is a ton of arthroscopies done on a heterogeneous group of people, but they're homogeneous in that they've been referred to an orthopedic surgeon. So they have failed care. So I don't know that the 6% is something that you could necessarily say the general population has this, but certainly individuals who end up in an orthopedic surgeon's office with a shoulder problem will. The question is whether it's relevant or not. Because most of these patients that ended up here had quote-unquote failed conservative care, and the main reason they were there was for bigger issues, like rotator cuff tears. So many of the people that had full thickness tears might have also had some form of a SLAP lesion. Okay, so the SLAP lesion may have not brought them to the surgeon, in other words. But you can see these are the initial classifications for SLAP lesions and make the most sense. There were 4 originally, and now there are 10 classifications. And I think sometimes these things happen because you have people in academic institutions, they're research fellows, or most orthopedic surgeons that are doing a fellowship in arthroscopy or sports, also to do research. And so it's like, what do I do? Well, maybe I can come up with different classifications for SLAP lesions. I think that's kind of how we got here. But if you look at their cohort, these 2,375 arthroscopies, partial thickness tears, full thickness tears, and Bankart lesions. Bankart lesions because of having a dislocation were much higher numbers. And the one thing I do know is if you had a Bankart lesion, they didn't count that into this cohort of SLAP lesions. But you could have had a SLAP lesion and had a partial or full thickness rotator tear. Okay? And this will make more sense in a few minutes. So type 1 tear. First of all, what is the superior labrum, anterior to posterior? This is it right here. Okay? So the anterior to posterior labrum is a very small area which kind of encompasses what you see here. It's where the bicipital tendon attaches. So your posterior labrum is actually a continuation of your bicipital tendon, and the bicipital tendon marches into that spot on the superior portion of the joint. And so this fraying here is probably present in everybody as we get older, unless you've never used your biceps before, right? We all have no choice but to use it. The type 2 is what was really kind of a controversial area, and this is either a partial or a full detachment of the superior portion of the labrum from the glenoid. But it is very isolated to this area. And this is that condition that, at one point in time, there were a lot of surgeons were making a lot of money by putting an anchor in that, or doing other things like what is called the biceps tenodesis, which we'll talk about in a bit. And so this was kind of, the main thing that you would see, like in throwing athletes early on. And so this is what that looks like in an arthroscopy. It's just peeling away, and it doesn't mean the whole labrum peels away, but at least part of it does. And more than likely, the clicking and popping that we all associate with a labral tear does not happen with these first two classifications. It happens when you get to things like a bucket handle tear, where a portion of that labrum, or maybe all of it, peels away from the biceps and flops down into the joint. So this would be like a bucket handle tear in the knee. We think of a degenerative tear in the knee, we treat that conservatively, you try to leave as much of the meniscus in as you can. It's the same with the labrum. But when you get into a bucket handle world, that's going to be obtrusive for most people's joints. If you use your arm particularly overhead, it's going to be catching and popping and clicking. And so this is when a surgeon says, it's time for us to do something. A type 4 lesion is the same thing as the bucket handle tear, but then there is also an extension or tearing into the biceps tendon itself. And you don't have to memorize these, just so you know. Just remember, you can always go, gosh, what is a type 2? You can look it up and it's there for you to find. But it does give you some perspective on when you talk about a slap lesion, it's really not something to be too excited about unless you've moved into the 3s and 4s. When we get to the 5s, this is different. This is a partial thickness tear that extends anterior and inferior. It's a Bankart type lesion that extends, and it can be full or partial thickness, but usually Bankart lesions are, again, because of one of two things: a dislocation, or number two, throwing athletes, people who are throwing a ball at 100 miles an hour, that can cause attrition. And eventually, over time, if your rotator cuff timing is off, the endurance is off, your mechanics are off, it can cause a full thickness Bankart lesion, which then ends up, in most cases, having the same type of outcomes or intervention, which would be going to surgery. If, we're in the world of professional sports, college sports, and sometimes high school sports, that's when you see these. But it extends from that superior slap area all the way down to the anterior inferior portion of the labrum. And so here we are at type 6. This is like almost a type 2, or really you could say in some ways a type 3, where you have a bucket handle, but now part of it is torn and that's dangling down into the joint a little bit more than your bucket handle here would be. And then, things can get much more dramatic. This is a tear that extends into the middle glenohumeral ligament. Remember, there's a superior glenohumeral ligament, a middle, and an anterior inferior band, and then a posterior inferior band. So the middle glenohumeral ligament gets bifurcated, essentially. There's an intra-substance tear of the middle glenohumeral ligament and capsule. A type 7, this kind of goes on and on. This is you can't even call it a slap lesion, really. It's a circumferential lesion. It extends from 6 o'clock all the way up to the slap area, or the superior portion of the joint. A type 9 is circumferential completely. So this is a joint that, if this is not a partial thickness, this is a full thickness tear, you have anterior, inferior, and posterior tears of the labrum. And the likelihood of you seeing this is probably pretty low. This isn't not a real common thing. And then a type 10 is one that is associated with an inferior labral tear, a reverse Bankart, so it's going all the way down posteriorly. So these lesions that you're seeing here can happen because of a dislocation or attrition. And now you have the full gamut of it. But when you think of a SLAP lesion, you're not thinking of these are really not SLAP lesions, these are actually labral tears, if I'm making sense to you. The ones that are truly SLAPs are really happening up here. So when they start to get circumferential, that's a labral tear. And Maffitt and Nord and Rio all kind of made these things up as time went on, and I think there's a little controversy around are we really going to classify these that way? Instead of just calling it a labral tear, it just happens to involve the superior portion of the joint, but it involves the rest of the joint as well. So when we move back to these are your quintessential SLAP lesions, okay? These four. And that's really what this is about, but I wanted you to know that there's 10, because you may read an op report or an article and go, what the heck is this? And the fact is, it's just really their labral tears. So what's the profile? The profile can be pain only. It can be popping, catching, locking. And that again is really the type 3s and probably the type 4s. The type 3s in particular that, you have something hanging in the joint. Mechanism of injury, it can be a lot of things. I think most people that you're going to see with a SLAP lesion, it's going to be an attritional injury. It's going to be somebody who throws a ball, does something overhead repetitively that might have a relevant SLAP lesion. And but traction injuries, if you can just imagine this, if your arm gets yanked straight down, straight out, like a traction type injury, then it's certainly possible to yank that off of the glenoid.
Can I ask a question on this? Because there's not enough or not any really work with hangers. Like there's a lot about throwing athletes, but not any work on like gymnasts or climbers, which are more hanging type of thing. And this is, I think, hanging or losing a foothold and just suddenly hanging is one of the main mechanisms of injury for SLAP in climbing. But there's not enough.
So I would say that it's probably hard to say with climbing what the mechanism is, because here, if you just look at this person carrying the couch, let's say that person steps on a baseball, and you can see there, missteps, you have this longitudinal force. The superior portion of the labrum and capsule are a restraint for inferior stability, or they contribute to inferior stability. Whereas if you're hanging, it's really the whole capsule. So it doesn't mean that you can't have a SLAP lesion, but you can hurt a lot of things by hanging. And interestingly enough, with all the gymnasts that I saw over the years, most of them didn't really have, they had shoulder issues, but it was generally rotator cuff type problems. Okay. And it was at a time where MR arthrograms were free-flowing because orthopedic surgeons were trying to learn, because it was early in the development of MRI, and they realized, we could do an arthrogram with this, so a lot of them got MRI arthrograms. And yes, they had the type 2 lesions, but they didn't have anything more significant than that. And so I don't know the hanging part, but just the sheer magnitude of what a rock climber or a gymnast does, I'm sure can contribute to injury to the entire joint, not just the superior portion, really the inferior portion as well. Yeah. So it would be interesting to look at literature to see if that it currently exists, but it's just the totality of what you do, I think, is probably the bigger risk than just hanging. Or the load that the biceps puts on that area would be another thing.
Yeah, because it's not all here, right? We're here, constantly just kind of tractioning like that.
Yep.
Um,
So that might be
be
different.
more it, yeah.
Yeah, particularly if you passively do it, which you can't imagine you would passively do anything, but, you know, I guess if you put your hand in a hole and you
Mhm. You're there isometrically, and then you have to kind of do a ballistic movement and catch the next one, right?
You're right, yeah.
Yeah.
So it would just be more the bicipital load, the magnitude of the biceps contraction that could actually injure that superior portion of the labrum. And then, you know, throwing athletes, just attritional things. That's attritional, not a specific activity, but the joint can get beat up because of secondary impingement. So slopping around of the humeral head can also contribute to injury of that area because if the humeral head rides up really hard, it can shear it. Weightlifting, you know, particularly things like Olympic lifts, deadlifting, those sorts of things, if your technique is not good, can contribute to this. And then water skiing, the incidence of slap lesions in water skiing is pretty high, and I would imagine that's because of the bicipital load. You're going from, like, people who are good water skiers accelerate to 70 miles an hour behind the boat, and they decelerate to like 15 miles an hour in their pre-turn. And then as they come out of their pre-turn, that rope is yanking them back up to 70 in a 30-foot period of time. I mean, it is really, you're getting slingshotting. And so it's the biceps and, of course, the brachialis load and all that, but the biceps attaching would really be what causes it, I think. So, you know, we're going to talk about a bunch of the tests and measures that there have been attempts at validating whether they really have reasonable reliability or not. This is a test that I had taken a course a billion years ago, and it was a Canadian physical therapist that was teaching the course, and he felt that sustaining a sulcus test, like you would do for inferior stability, and keeping it there, if you reproduce pain with that, and you're confident that it's not because of a supraspinatus issue, then there's a strong likelihood that it could be a slap lesion. And so this has never been put to the test of, you know, reliability testing or looking at the diagnostic utility of it. But I've had enough patients now where this is something that actually really kind of tells the story. It really helps with that differentiation. And the hardest thing is, most of these patients, the confounding variables are the fact that they seem like a rotator cuff problem or an impingement problem. And if they don't respond and you think the care has been good and they fit that mold of an athlete who's, you know, not somebody who has a rotator cuff tear and then they might also have a slap lesion, that's a given. But a younger person, this could help you. You just have to make sure they relax, because if they don't relax, they're turning on their supraspinatus, then that's confounding. Okay, how many of you have heard of the active compression test? So if you remember, well, you probably don't remember, you guys are probably fairly born, but you know, O'Brien in 1998 published a study on the active compression test, and it had kind of two tails to it. One was for labral pathology, and they didn't necessarily say it's for slap only, but that was the gist. And then the other part was it could also be used for chromoclavicular joint arthropathies. And when they published this, and you look at this, sensitivity 1.0, specificity 0.985, it's almost unbelievable, because it's very hard to find tests that are both sensitive and specific. And so this was like, wow, you know, this is really incredible. Well, it's been now put to the test of time, and I think this last publication by Davis in 2019 was a bunch of pooled articles. Basically, they took all the articles that were well done that looked at the diagnostic utility of the O'Brien test, and this is really what it came up with. And this includes, you know, a big number, 318 with this 1.0 and 0.985, and so it was watered down considerably. The sensitivity is moderate, and the specificity is a flip of a coin. So by itself, the active compression test is not something that you can rely completely on. And I think your clinical acumen will teach you that some of just your passive movement testing and your clinical acumen on how somebody responds signs and symptoms wise will help you. Now, if somebody's got clicking, popping, locking, you already know from your history, like there's probably something obstructing the joint. But when we're talking about a type 2 lesion, the type 2 lesions really now, treatment is what you do. Hands-on care, exercise. You optimize the patient for hands-on care, or for exercise. And so, with O'Brien's work, I'm just gonna go to the pictures here. There's 2 steps to this. Number one, the way they described it was you would have your arm about 10 to 15 degrees away, out of the sagittal plane and really across the body. In full internal rotation, you would manual muscle test, and if that brought on pain or you had clicking or popping, it was considered a positive test only if, when you externally rotated and repeated the test, the symptoms were less. And also the reason Gail's pointing to the AC joint is because if you get AC joint pain with this, then it's not a labral problem, it's an AC arthropathy. And it's too good to be true, is the take home here. And you have to realize that all these special tests are too good to be true, with the exception of some of the stability tests when you dislocate somebody out of the joint by accident. That's a real thing, right? Or you feel someone's humeral head move way forward in the joint. We'll be practicing this stuff next week. Then those are things that you can hang your hat on. But all these tests, they're down the road. When the patient non-responds, then you can say, all right, I'm gonna look at these tests, and if this was negative, then the likelihood would be a lot less that, because, when you say there's, in a pooled studies, there's 70% chance that you're gonna pick it up, then having a negative test is a little bit meaningful. But you can't hang your hat on what O'Brien published in itself.
Where are we looking for pain, like specifically? Not AC joints, so.
It's really subacromial.
Oh.
Which, the other thing is, pain, what if it refers anterior joint line? You say, well, that kind of fits a periarticular, intra-articular problem, but it's also where the AC refers. So it's not as straightforward as, you would think. And when you look at what their, reference standard is arthroscopic visualization, let's say all these are athletic patients, which they were, then there's a 35% chance that you might have some type of labral pathology, whether it's driving your symptoms or not. So it was really nice at the time, like, funny, we had something to hang our hat on, and then it really didn't pan out. But it doesn't mean you throw the baby out with the bathwater. You might still fall back on this, because if it is asymptomatic when you test them, then that helps you. Okay, so then there's the crank test. And this guy, Steve Liu, published this, or he was gathering the data. I worked with him at UCLA, and there is some question as to whether or not he falsified some data. Okay, so but I think the test has got merit, particularly if the person says I have clicking, popping, and locking of the joint. Okay, the sensitivity and specificity are really high here too. Look at these likelihood ratios; they're off the charts. Arthroscopy was the standard. The comparison with MRI, and so the radiologist that read this, Leanne Seeger, who was a very well-known radiologist called him out. It was in I think it was the American Journal of Sports Medicine. She wrote a commentary, like, a letter to the editor that some of the way this data was looked at might not be what it is, and it created a lot of controversy. You can imagine, but I still think the test is reasonable. And so here you have the patient, you pull them up into a reasonable amount of abduction, but it doesn't have to be there. And essentially, what you're doing is you're internally and externally rotating, right? And you're trying to scoop, it's like a McMurray's test for the knee. You're trying to scoop this out. And so it can be done, what you do is load the joint up in a reasonable amount of abduction, and you're doing gentle, not hard, but gentle longitudinal loading of the humerus, and then internally and externally rotating. But you don't have to stay up there. You can move down, because you don't know where you're going to pick it up. You might pick it up down here, just moving in and out down in a neutral posture. But you can take it all the way around the horn if you really suspect that there's a instability of the labor. That's where this comes in handy. You can imagine this would hurt most people if you have a subacromial issue, right? It's a little bit vigorous. So that's kind of a given, and this is like doing a impingement 2 test, if you will, with the arm way overhead. So if you're doing this early on when somebody is acutely painful, pain might be the limiting factor, not a mechanical result, meaning clicking or popping. The biceps load, there's a couple of different versions of this. This has got a pretty decent sensitivity and specificity for a slap lesion. And all you're doing is you're using the biceps to tension the superior labrum. And so this is what it looks like. There's 2 ways you can do it. So you position them at about 90 degrees, but it doesn't have to be at 90. It can be higher if you want it to be. And you do very gentle loading of the biceps. So you're trying not to get a lot of irradiation into the rotator cuff musculature. You're going to have it turn on, but you don't want it to be a big time force. So you're loading the biceps just by doing elbow extension, and they're holding against you. The other way this can be done, which is more subtle, is resisted supination. Either one is reasonable. I like the resisted supination one because you are getting less elbow flexor activity, because with elbow flexor activity, you're getting brachialis too, and that has the tendency to make things radiate more. So if you just do supination, resisted supination, you're going to turn the biceps on. And if that alone gives them their shoulder pain, and they have non-responded to your care, it's conceivable that they have a slap lesion, but they might have a type 2 slap lesion. If they non-respond and you don't go anywhere, then maybe teaming up with an orthopedic surgeon or a sports medicine doc, offering an injection, seeing how it goes, might be a reasonable step. Okay, so you're going to run through a lot of things in the literature on slap lesions. And I think the reason why is because it's such a nebulous condition, if you will. It rarely stands in isolation, and so to find it in isolation is tough. And so this is Chad Cook was the author of this study at Duke, and they looked at the presence of slap lesions using arthroscopy. And the thing here is the average age is 45 years old. So you right away ask yourself, is this should we have really included people who are non-athletic? Because what's the relevance of this? And he actually, in his discussion in this article, wrote about that. Like, the relevance is questionable, because maybe if we took everybody 40 and under, it would have more relevance. Right? But what they looked at was these procedures, and some of them we haven't talked about yet, but you know what the biceps load is, the active compression test, speeds test, very simple test, You're out like this, you basically resist shoulder flexion. The labral tension test and labral shear test are different, and there's a couple pictures of them here. So this is the O'Brien, this is Speed's test. This is a very weird way of showing the labral shear test. This is the dynamic tension test. I'm not sure, maybe, no, this is the biceps load, and this is the dynamic tension test. And so you have to remember, this was right at the tail end of when special tests were really important, particularly to physical therapists. And now using this as a way of diagnosing these things is becoming less and less relevant. But you should know what they are, or at least have some idea what they are, because you're going to read about it in the literature. And you may do some of these on your patients. We're going to cover the ones that are really important to do today. Okay? So at the end of this whole thing here, Chad Cook stated that the active compression test combined with the labral tension test in combination, if you were going to use special tests for this, were the best way to go. And you would ask, well, why the heck didn't we do the dynamic labral shear test? Because it has a 92% sensitivity, but the dynamic labral shear test is not for slap lesions. It's for anterior labral issues. You're basically shucking into the labrum, shearing the labrum to see if it creates pain. So that's why he selected these. He's like, if you're going to look at the two best tests, these are them. And so we're going to cover these in lab today. But I still think, even though the biceps load, sensitivity was low, the specificity was low, by itself, if you really narrow it down and you've done your due diligence, you've treated the patient, and they haven't responded, and you can bring their symptoms on with a little bit of supination, manual muscle testing, and it's focal to that area, then it might point you in the right direction. And I think part of this problem here is that you have this broad age group, which shouldn't have been in there. There's just too many other things that could be causing symptoms. Kevin Wilk, I'm sure most of you have heard of Kevin Wilk. He kind of looked at all these different studies done for the active compression test and showed the variations that you saw from O'Brien, which was 100% sensitive to 99.5% specificity. There's some variation there too. And the differences that other studies found. We already talked about that pooled study, so this is probably redundant. But here, they're looking at 90% sensitivity, 97% specificity for the biceps load. This is a group of individuals who are overhead athletes. So there lies the difference in the Chad Cook study and this study. We have a homogeneous group of people here. And that's really what is applicable to. And if you look at MRI, so this is MRI kind of across the board. Sensitivity is okay, but some of these, this is all just standard MRI, not MRI with contrast. So if you look at this, here is your routine MRI. By the way, on the right here, this is the quadrants. This is your superior quadrant, posterior, superior, and so on. And this is how the labrum is divided up. Okay, if you wanted to read a radiology report and they start quoting quadrants, this is what you're dealing with. But really, it's more than quadrants. So MRI, routine MRI, for picking up small lesions, okay, type 2 lesions, it is going to probably miss it most of the time. But MRI arthrogram, if you really are suspicious of a type 2 lesion or something that is maybe more extensive than that, then you want to, if you're sure, then you're going to get an arthrogram. But remember, an arthrogram is not pleasant. They fill the joint with a radiocontrast dye. The patient needs to know that that's going to happen. But that's what, if you're really confident, and that's what your workup is, you said, I failed, we need to move you on, then this is what they need. And so, here's a nice T1 weighted image with contrast, and you can see this little area here, this cleft that has some of that radiopaque dye go up into it. If this was a bucket handle tear, it would be picked up on an MRI. Those things get picked up in the joint. But anything that has bifurcation of the capsule, extension into some of the ligaments requires this. But a Bankart lesion doesn't, right? So if you have a Bankart lesion, you can pick that up very easily on a standard MRI. So this is one study, but it does kind of point, so in the 90s and 2000s, our surgeons here, if they had the skill, and certainly surgeons in the private sector, were doing a lot of surgeries on type 2 slap lesions. And at some point, there was some question, like, is this really necessary? Because what it did, it's kind of like subchromial decompression. You rest for a while, like here you have an athlete who is like, I can't stop training, and then all of a sudden, they can't do anything for 12 weeks, really, that's of any effort. And more than that, actually. So what they did is they looked at a primary repair of the labrum, and they also looked at a biceps tenodesis, which I've always kind of wondered about, but all it is you basically hack out a portion of the biceps tendon from its insertion in the labrum down to the bicipital groove. And now you've taken that unwanted tension away from the superior labrum. But you've also lost a suspensory mechanism, because the biceps does aid in humeral head elevation, or and some people believe it actually functions a little bit as a depressor as well. But it does help as a suspensory mechanism. So now you're taking it, you're drilling a hole in the floor of the bicipital groove, and you're shoving it in that hole. So that's what a tenodesis is. And so the assignments were done randomly. The type of lesion was confirmed by MR arthrogram. And so they either had a labral repair, a primary repair, which is usually sutures or a suture in the anchor, depending on the size of it, the biceps tenodesis, or sham arthroscopy. So this is kind of like that knee arthroscopy article I think that Ryan talked to you about, where they just basically make incisions where they would be putting the scope in, and that's it. The outcomes at 6 months and 24 months were equivocal. That says a lot about the net worth of this surgery. It doesn't mean that you would never do surgery for this. Okay, so if you fail rehab, and it's good rehab, then what else is there? Maybe an injection, but most people don't like to inject the young shoulder in particular. And so, the question is it the rest? Is it the rehab? They all had rehab afterwards. And the reason it was evaluated at 6 months is because that is the beginning of the time you can return to sport after having a primary repair or a biceps tenodesis. And I don't know what they told the people who got the sham surgery, like what they got. If you had a repair of your labrum, I guess they must have lied to them. So this really changed, particularly in Kaiser Permanente, like, do we really need to be doing all these surgeries? So if you ever talk to one of our sports surgeons and you say, hey, this person's got a slap lesion, you got to make sure they understand that they have failed everything. Is it reasonable to look further? Because there really is nothing else between rehab and surgery unless an injection is something that the person's willing to try. So what if you have a slap repair. You truly have a repair, and you're a baseball player, not necessarily just a pitcher, but just a baseball player, and you've had a slap lesion. What are the chances that you have returned to sport? Because that really is the definition of a success, right? Successful return to your sport. And so these patients were contacted by phone 2 years post-op. I think like 133 of the 216 actually followed through with getting back to the people who were doing the surveys. And here's, we have high school, we have college, and we have pitchers and non-pitchers. So the results are, pretty darn long-term follow-up. 62% return to play successfully. So there was no difference between the procedures that they did. The non-pitchers actually did pretty well. The people who were going to return to pitching, not as well. Because obviously pitching there's a lot more demand. And the question would be, what was driving their condition to begin with? Which is, we're going to go through a kind of a whiteboard discussion this morning and kind of talk you through a few things that probably most people don't consider in the treatment of these conditions. Okay. Any questions about this, or comments you want to make about your own experiences with slap lesions? It's not that they don't hurt. They cause symptoms, and it's not to minimize them. It's just